Okay, let's start. So, hello everyone. I hope you're all doing well. Thank you for joining us today for another one of our surgical lecture series. My name is Soha Farhat. I'm a final year medical student at AUB, and I'm part of the founding team of the Women in Surgery Interest Group Lebanon chapter and the Association of Women Surgeons at AUB, and I hold the position of the social media coordinator on that team. Before I introduce our speaker for today, let me just remind you of a couple of instructions so that this session runs as smoothly as possible. First, please make sure your microphones are turned off for the entire length of the session. Second, please write all of the questions you have in mind in the chat box, and our speaker will be ready to answer them all at the end of the session. And third, and most importantly, enjoy. So now we're ready to begin. I will start by introducing our speaker. Our speaker for today is Dr. Bassam Osman, a third-year general surgery resident at the American University of Beirut Medical Center. He received his medical degree from the American University of Beirut in 2017, and his specialty of interest is cardiothoracic surgery. You might recognize Dr. Osman from the multiple interviews he participated in regarding the devastating Beirut blast on August 4th of this year. In today's lecture, Dr. Osman will be discussing a topic that many of us are curious to know about, and that is surgery in the times of COVID-19. With the rise in the number of COVID cases in the world, healthcare workers had to quickly adapt in order to continue providing the best care to patients presenting to the hospital in the safest manner possible. In very little time, new guidelines had to be created and continuously updated, and strict strategies of infection control had to be implemented to limit the further spread of the virus. Dr. Osman will take us through all the ways surgeons had to learn to operate during such a pandemic, pun intended. Dr. Bassam, the floor is yours.
Hello, everyone. Thank you, Soha, for this keen introduction. Let me share my screen first. Okay. So, first of all, let me give a word of gratitude for all the people who are behind the scenes of this incredible job. Today's lecture will be outside the general surgical knowledge as compared to the other lectures, and it will be in the context of what we're living today in terms of the pandemic. In this lecture, we'll be tackling many of the notions that were disrupting the surgical field during this last year. But first of all, let me present you with this quote from Aldous Huxley. You might recognize him as the author of Brave New World, a novel similar to 1984 by George Orwell, very dystopian novel, and it would put you at the extreme of what's happening today. Aldous Huxley says that men do not learn very much from the lessons of history is the most important of all the lessons of history. And I'm presenting you with this quote just to say that what we're facing today and the reaction of the healthcare system today to the COVID situation appears to be common knowledge, appears to be intuitive. However, it's just an accumulation of all the knowledge that we were presented with during previous pandemic, during previous epidemics, and what appears to be very natural and a very adequate response today was not the case back in the days. So I will take you on a brief journey back into the pandemics that humanity faced and how these pandemics one by one have taught us how to deal with COVID-19 as we deal with it today. So the Black Death, which was one of the first pandemics to be known in our recorded history, it happened in the 1300s by a pathogen known as Yersinia pestis. The fatality was up to 100% if not treated, and the outbreak killed around 400 million people, most of whom were located in Eurasia and North Africa. So the medical scene that was instituted back then is very much different from the medical scene we witness today. So there were three classes of medical practitioners in Europe. The physicians who were at the top of the pyramid. They were very well respected. They were university scholars and subscribed to ancient Greek theory of humoral illness and what have you. And then the next class, or the worst class of physicians, were the surgeons, who lacked the prestige of the physicians, and their techniques were deemed to be very aggressive, very crude. It was mainly bloodletting and boil lancing, which, if you want to call today, is a simple incision and drainage. And then the third class, or the bottom of the pyramid, were the barber surgeons, and these were inferior to surgeons, and their expertise was mainly tooth extraction. So during the pandemic at that time, the physicians tried to solidify their prestige and widen the gap between them and the surgeons. However, their techniques, which mainly constituted of humorism, which in summary is having too little or too much of a certain fluid of these four fluids in your body, would lead to disease. However, this theory and these techniques did not address the pandemic and did not satisfy the public at that time. So they gained the mistrust of the populations, and the highest class of physicians had fled to the countrysides, and that created a void which was the perfect opportunity for the rise of the surgeons at that time. So surgical societies started to coalesce and organize into healthcare systems. And for the very first time in history, we started seeing surgical societies. Surgeons had to be approved by a master surgeons, and they had to undergo examination overseen by 6 surgeons. But also surgeons themselves distance themselves from their inferiors, who were the barber surgeons. So they started wearing long white robes. Moreover, surgeons began publishing manuals and practical treatments to open the space for the surgical therapy as compared to the more trendy therapy at that time, which were humoral theories. So why am I mentioning this? Because the Black Plague at that time, the Black Death, provided a catalyst for growth of the surgical societies throughout medieval Europe by highlighting the inadequacies of the existing medical therapy. So for the first time in history, the surgeons had a role and had an opportunity to rise at that time. Move a few hundred years forward, and humanity was struck by the Spanish flu, which hit in 1918 and was caused by influenza A. It infected around 25% of the world's population, and the death toll was around 20 to 50 million, which was more than the casualties of World War I at the time. However, the Spanish flu, unlike its predecessor, came in a time where we had a better understanding of diseases, and the germ theory was already established. So healthcare professionals at that time knew that the Spanish flu was a pathogen that was transmitted via infected body fluids and tissue or infected droplets. So this better understanding led to a better reaction towards the pandemic. And as civilian healthcare facilities started getting crowded, field hospitals were being erected. However, having all this understanding of the germ theory at the time led to a different reaction, one that is centered around cleanliness, especially in those hospitals that were field hospitals. They were a state of art in terms of hygiene, fresh air, reusable masks. And for the very first time, we started to see that truly the effect of hygiene and cleanliness led to a better outcome in patients. So the mortality then in these field hospitals was down to 10% as compared to 40% in conventional healthcare facilities. And it was mainly due to all this hygiene restrictions. And if you think that your mask is causing you distress or is annoying you, these were the masks back then during the Spanish flu. And it was mainly around 6 to 7 layers of gauze on a wire frame that they had to wear all day. And I don't think it compares to what we're living now. So the 1918 Spanish flu pandemic saw the widespread implementation of hospital hygiene and public health measures informed by the germ theory, as we said, that remained the foundational to modern surgery. So all the hygiene, all the sterility, all the cleanliness you witness in hospitals nowadays was not the norm, was not the culture back then. And thank you to the Spanish flu pandemic, this notion of hygiene started to become a pillar of every procedure and every hospital word we have now. So the rise of the surgeon and the concept of hygiene. HIV and AIDS. So the HIV hit us as an epidemic in 1981, and the death toll was around 50,000 deaths. And with advancement in antiretrovirals and drugs, we were able to decrease that toll to 15,000. However, before understanding the modes of infection and the discovery of antiretroviral drugs, this epidemic specifically induced fear and discrimination among patients. So surgeons at that time refused to treat patients due to the huge insecurity they felt towards the risk they were dealing with. And their insecurities were even translated into a legal note known as the no duty rule, where no physician had a duty to treat a particular patient. And the freedom of choice was supported by professional organizations. So I want you to put yourself back in the time where you had the right to refuse to treat a patient just because he is seropositive or infected. And this attitude, the attitude in this quote was trendy back then. So someone says that I've got to be selfish. It's an incurable disease that's uniformly fatal, and I'm constantly at risk for getting it. I've got to think about myself. I've got to think about my family, and that responsibility is greater than to the patient. So this tension between physicians holding risk in treating patients grew, and it did not sound right for a physician to refuse to treat a patient. So the AMA in 1988 issued a statement where it concluded that a physician may not ethically refuse to treat a patient whose condition is within the physician's current realm of competence solely because the patient is seropositive. And furthermore, not just being ethically not right, but also legally in 1990 by the Americans with the Disability Act, discrimination against seropositive patients was made illegal. So the HIV/AIDS epidemic raised ethical debates regarding the surgeon's duty to treat patients and the principles of accepting a reasonable level of risk and not discriminating based on seropositivity have prevailed. So the notion of healthcare physicians being at the center and at the front line, as we see today in the COVID pandemic, and this glorification of the physician and the healthcare workers as a whole was not the case back then. So the tension was whether healthcare professionals should accept a reasonable level of risk in treating patients. And this is common sense today. And this is mainly because we've been through that fight before. And finally, Ebola in 2014, which hit West Africa with 11,000 deaths and a 40% mortality rate. The thing with Ebola is that the symptoms mimicked very much the symptoms of acute abdominal pathologies. And with the lack of imaging to provide an adequate diagnosis, especially that it hit a resource-poor area of the globe, their patients with surgical abdomens were misdiagnosed with EDV and therefore were denied from surgeries due to misdiagnosis. And surgical volumes plummeted down to 19%, and many patients were dying of untreated surgical conditions such as incarcerated hernias and perforated ulcers. So this confusion regarding diagnosis and misdiagnosis in terms of surgery and Ebola patients brought the sense of guidelines and the standard of care into light. So guidelines for treating surgical patients had to be set, and the American College of Surgeons adapted with the CDC and realized multiple guidelines, including organizing the surgical workflow on patients with Ebola or suspected Ebola, proper donning of PPEs, and stressing minimally invasive procedures and conservative management of some surgical cases. However, the problem back then, even though guidelines came into light, and even though societies provided a standard of care, is that it was hard to implement in an area that is very poor, such as West Africa. So the West Africa Ebola epidemic revealed the vulnerability that surgeons in resource-poor healthcare systems faced during infectious disease epidemics. To compare it with now, so what they did back then is provide a standard of care for everyone. However, it was difficult to implement in certain areas. Looking at the COVID-19 situation today, there is a basic level of a standard by which everyone should go through. However, specific lockdown restrictions, isolation restrictions are very much contextualized into the situation of the country itself and left for the discretion of authorities and physicians there. So what we learned is that there is no size that fits all, and guidelines, even though important, they should be individualized and put into context of the specific country we're dealing with. So coming to COVID-19, just to set the scene real quickly, in December 31, WHO informed about cases of unknown etiology pneumonia detected in Wuhan, China. In January 30, WHO declares public health emergency of international concern. In February, US reports first COVID death, and in March, the WHO declares COVID-19 as a pandemic. In Lebanon, our first case was reported on February 21, and we've been struggling with increased number of cases, as you see now. However, our focus in this lecture will be the effect of this pandemic on the global surgical workflow and the disruption it has caused. Taking a look at this, you can realize the number of cancellations depending on the domain of surgery we're talking about. So the blue color is around 90 to 100% cancellation of surgeries, especially for benign disease. This was a little bit less for cancer surgeries and a little bit less for obstetric surgery. So COVID-19 disrupted the flow of hospital services globally. And this reduce in elective surgery was aimed to, first of all, allocate manpower to support the wider response. So you had to move people from surgery into medicine and critical care to support the manpower there, preserve equipment and supplies, releases wards and ICU beds for COVID-19 patients, empty spaces provides you with vacancy, and allows recovery areas to be used as ICU units, and finally ensure patient safety and inpatient virus transmission, where you avoid bringing patients with elective pathologies and elective surgeries into a risk of contracting COVID-19. So not only reserving manpower, but many studies started questioning what is the outcome of operating on a patient with COVID. And there was a need to answer a few questions regarding elective surgery. First of all, quantifying and estimating the effect of canceling elective surgery on a global level. So what would happen if we stop operating on elective cases? Canceling surgeries will create a backlog that we will eventually have to deal with after the pandemic. So all these elective surgeries that we've been canceling, they will go nowhere. They will come back and strike us as a huge load that we won't be able to deal with. And finally, determine the outcomes of surgery in patients who are COVID positive. So an initiative was launched by a group of physicians known as the COVID Surge, and their efforts were concentrated on answering all these questions in a context of a global sample where they gathered data and research from all over the globe. And their first publication was the outcomes of mortality and pulmonary complications in patients who are COVID positive. And the results were striking, and they were very early during the pandemic. And it showed that there is a 24% 30-day mortality in patients who are COVID positive. Moreover, as you'd expect from COVID being a respiratory disease and the respiratory pathology mainly, there was a 51% post-op pulmonary complications. So what they concluded is post-op complications and mortality is higher than in the pre-COVID era. Surgery should be postponed, and non-operative management should be used whenever possible. So if the case is elective, whatever happens, try to avoid taking the patient into the operating room, especially if he is or she is COVID positive, because the morbidity is much, much more than you'd expect as a non-COVID patient. Moreover, studies from Italy also started coming out stressing the same thing, with a 9.5 odds of mortality as compared to controls, and complications of pulmonary complication up to 35.62 times than non-COVID patients. So the numbers were really discouraging, and surgeons started shying away from operating on COVID positive patients, especially non-urgent operations. So COVID Surge also published another report back then. So now we're in the context where people are being relocated, surgeons are being relocated, spaces are being allocated for COVID patients, and the outcomes of patients, COVID positive patients, are very bad, and huge cancellations are all over the globe. So this has also to be studied, and they found out that in 12 weeks of disruptions globally, there were 28.4 million cases that were canceled in 12 weeks. We are not speaking about the whole pandemic, we're just speaking about a short time period during the pandemic. 28.4 million cases, elective cases, were canceled. So this number is going nowhere, and this is a number that is now much, much more, and we'll have to deal with later on. So the key question then began to be is, how do we decrease this backlog, and trying to decrease these restrictions of we're not going to operate on elective cases all in all in the during the COVID pandemic. So the question was, does this surgery need to be happening in the next hours, next days, or can it be delayed without compromising safety and outcomes? Moreover, the issue of taking risk as a healthcare practitioner, as we saw previously during the HIV and AIDS era, also came into light. And a physician said that there is no emergency in a pandemic. Since Ebola times, the center is and should be the healthcare provider. So there is always this tension regarding how much risk should healthcare professionals and especially surgeons be taking. So aside from the history and the center problem of surgery during COVID, which is the cancellation of the surgeries, the bad outcomes, and the accumulation of a huge backlog that we have to deal with, there are few notions that I would like also to tackle in the context of this. presentation. First of all, the surgical or operating room workflow. So in the operating room, there are many things that happen behind the scenes before the surgery takes place, many things that are happening as the surgery takes place, and many things that happen after the surgery takes place. And changing the operating room and the operating dynamics during COVID is a huge hassle and a huge complex process of changing a whole workflow into something else. I will not go over this because it's beyond the lecture as a whole, but it's just to show you the complexity of doing one operation in the COVID era. And this complexity is mainly because being in the operating room carries one of the biggest risks of being infected with COVID-19. Either be it the anesthesia or the surgical procedure itself, they are all aerosol generating procedures, putting all people inside the operating room at risk. So many considerations had to be taken when tackling surgery during COVID, especially the COVID status of the patients, protecting the inpatients from infection, PPE availability, the workflow in the operating room, protecting the healthcare workers, and the urgency of the cases. So to put things into perspective, the issue of COVID screening. So this was something controversial early during the pandemic, even though it's very standardized now, very intuitive today. However, early on, that wasn't the case. So should we screen everyone undergoing surgery for COVID-19? The rationale for screening everyone is that there are people who are asymptomatic carriers. They will never develop symptoms. However, they can transmit the disease. So testing will help triage patients to COVID or non-COVID operating rooms, and later on will help you take the decisions and the necessary precautions when disposing such patients. It will help you preserve PPEs and mainly N95 masks, knowing what is the risk at hand. It will help protect healthcare workers and avoid surgery if feasible if the patient is COVID positive, because as we said, you have to avoid all this morbidity and mortality that comes from operating on a COVID positive patients. So several studies have tackled the issue of screening everyone. And this is a very recent one from the COVID Surge Initiative. It was a multi-center cohort study. They screened adults undergoing elective cancer surgeries, and they recruited around 8,700 patients. The preoperative nasopharyngeal swab testing was beneficial before major surgery and high COVID risk areas. And the outcome they studied was the pulmonary complications of those patients and the healthcare infections after surgeries. And it showed that PCR testing for everyone, even though the benefit was less in minor surgeries, it was beneficial for everyone to be tested before undergoing any type of surgery. At AUBMC, we screen all patients undergoing invasive procedures or those requiring any form of anesthesia where there will be a risk of aerosol generation. We used to take it before 48 hours, but now the window has expanded to 72 hours. And COVID PCR is now incorporated in the preoperative checklist. Some hospitals also introduced phone screening for all patients about symptoms and education about visitor restrictions. So aside from the PCR testing for all patients, this has created the issue of operative delays and conservative management. So surgeons are now left in a place where the outcomes of COVID patients are terrible, and there is a huge surgical backlog that is accumulating. However, there are cases that are not life-saving per se and are not that elective that you can easily dismiss them and postpone them. There are cases that just can't wait. And the delay in these cases will lead to their progression and eventually more complications and more morbidities later on. And the thing is that we have to understand is that the delay and regarding the surgical management of these patients, the responsibility is not held only by the healthcare system or the providers, but also surveys showed that there are many patient factors that are preventing the patients from presenting to the hospital in the first place. So denials, ignorance, fear of infection, and lockdown, travel inconvenience, and financial in the context of our situation. These are all factors that are holding patients from presenting to the hospital for treatment of their pathologies, which will later on develop into more complicated pathologies, deeming the treatment much more difficult. So this was a study that compared the onset to door in stroke patients. In other words, how much time does it take the patient to present from his house or from the first onset of symptoms of stroke to the hospital. And as you can see in the gray bar, the time that it is taking patients in the COVID era is almost double, as patients are afraid and insecure about coming to the hospital, especially even though we're speaking about a very bad disease such as stroke. So patients without life-saving procedures, even if they present, then you are left with the delay that happens inside the hospital. So patients without life-saving procedures wait almost 12 hours in the emergency room pending the results of their COVID testing, the isolation precautions, all the restrictions. And there were many reports during the COVID pandemic about rotten toes, ruptured appendices, and very bad gallbladders, just due to the fact of the delay that happens from the onset of symptoms to presentation to the hospital, and when the patient is in the hospital, the delay that happens due to the COVID protocols. My experience from seeing consults in the ER at the AUBMC is that we have allocated around 45 minutes for a PCR for a patient who requires an urgent operation or a life-saving procedure. And this comes as a call from the ER physician or the operating surgeon to claim the surgery as life-saving, hence removing all these delays. And this is just to say that mindful thinking about the delay in the ER could lead to improvement in the waiting times. Moreover, aside from the delay, there is insecurity from surgeons and shying away from performing procedures when there is a conservative alternative to operating. And the literature is now full of studies pushing surgeons to perform conservative management on appendicitis, on fractures, gallbladders, etc. So moving on, another topic is the personal protective equipment as a whole. And the question that came to light early during the pandemic is, if there is no PPE, should we refuse to operate? In February, the WHO published a rational use of PPE in COVID patients. We were still back then questioning whether COVID is an airborne or not, is airborne transmitted or not. And it pointed out that early during the pandemic that the PPE is lacking and there is an inability to ramp up production to keep up with the PPE requirements that are expected. And in July, transmission, a report from WHO showed that transmission can occur via droplets 5 to 10 microns and aerosols less than 5 microns. So the CDC published guidelines to standardize the use of PPEs that consisted of N95, eye protection, gloves, and gown. And the respirators with valves, the one you see people wearing around, should not be used as the exhaled air could contaminate the surgical fields, and they protect only the person wearing this mask, but not his surrounding. So if N95 are short, they should be preserved for procedures involving high-risk techniques or involve anatomic regions that are high of viral load. Moving on, another aspect that was disrupted during the COVID pandemic is ventilation. So ventilation inside the operating room. So what I want you to know that ventilation inside the operating room is a very complex subject and difficult subject to tackle. There are many things that happen behind the scene that we are not aware of, and you can spend your whole life going in and out of the operating room without noticing the issue of ventilation inside. So just for you to know, negative pressure ventilation is ventilation that pulls the contaminants from the floor to the ceiling. It is good for removing the virus away from the environment. However, imagine you bringing all the contaminants from the ground into the surgical field. So this is what negative ventilation does. It pulls up all the contaminants and makes the surgical field a worse contaminated place, putting the patient at risk of surgical infections, etc. As compared to positive pressure ventilation, which is the standard, which is the norm, it is the flow of air from the ceiling to the ground in order to push all the contaminants away from the surgical field. So what is the best method of ventilation when dealing with COVID virus? Many studies, and especially those dating back to the SARS pandemic, have very well established that negative ventilation is the best form of ventilation when we're dealing with viruses in the operating room, despite exposing the surgical field to infections. So recommendations regarding ventilation is understanding the airflow in operating rooms is essential to minimizing risk of infection. Isolated rooms with separate access and negative pressure are recommended. In case negative pressure is not feasible, and that is because you have to change the whole circuit, you have to introduce filters, and it's not easy to change a positively ventilated room into a negatively ventilated room. So in case negative pressure is not feasible, positive pressure should be halted during the operation. So at least stop the positive pressure, and 20 minutes after the patient has left the theater. More than 25 air exchange cycles happen per hour, and the use of high-efficiency HEPA filters should be used. So changing the turnover between patients, the time between patients should be at least 15 minutes to allow cycles, the cycle of ventilation inside the room to clear around 99% of particles inside. So another very famous controversial topic that also came into light during the COVID pandemic is the use of laparoscopy. So early during the pandemic, a study from Italy advised surgeons to move away from laparoscopy and minimally invasive procedures, as they are very high risk and aerosol generating procedures, and recommended open laparotomy for all patients. And this was based mainly on studies back from 2014 and 2016 that focused on detecting hepatitis B virus in the aerosols from laparoscopy, and these were extrapolated into COVID virus, and thus the recommendation was, and the common sense was, to move away from laparoscopy. However, with COVID-19 and knowing, acknowledging the benefit of laparoscopy in certain patients as compared to open surgery that could be very morbid, a joint statement by SAGES and the European Association of Endoscopic Surgery set out recommendations regarding safety of laparoscopy in COVID patients. So the bottom line is that we cannot extrapolate the knowledge we know regarding laparoscopy in the context of hepatitis virus into COVID virus. And there is still no evidence against laparoscopy in COVID positive patients. So the recommendations are as following. The surgery should be performed by the expert surgeon to minimize the time. So residents going in and out, mingling with laparoscopy is not allowed. Closed circuit smoke evacuation, careful port insertion, minimize the ports and use the smallest possible incisions. Consider balloon ports to reduce gas loss, minimize instrument exchanges during the operation, decrease abdominal pressure, minimal use of energy devices, and the pneumoperitoneum should be evacuated through a filter prior to trocar removal. So all the efforts are to make this circuit a closed circuit with little generation of aerosols to the outside of the abdomen. So in brief, both open and laparoscopy surgery are aerosol generating. No current evidence against laparoscopy in COVID. Advantages for laparoscopy in certain patients should be heavily considered. Examples are shorter hospital stay, faster operative times, and the decision should be taken based on individual cases. And this picture is here just to give you a sense of how difficult it is to maneuver a COVID patient inside the hospital, from the operating room to the recovery room to the imaging department. So it is a hassle, and operating when the operation is needed and to know when to avoid surgery in such patient, what to dismiss and what not to dismiss is important, because getting a patient in there at the end of the day is a hassle and puts a lot of risk on everyone. Anesthesia in COVID. So we all know that anesthesia is high risk, mainly due to the aerosols generated during intubation and anesthetic procedures. So as in surgery and laparoscopy and all the topics you mentioned, there were also standardized recommendations regarding performing intubations. So for example, the best person to intubate should be intubating, immediate cuff inflation, viral filters. Moreover, some hospitals adopted these containment boxes to make the intubation setting an isolated space to minimize the exposure of the physicians during intubation. Some hospitals, and it is becoming more of the standard today, added additional filters into the circuit, the anesthesia circuit. All these efforts are to minimize the exposure. Finally, few prospects regarding the COVID pandemic in the context of surgery as a whole. As I said, the major problem that we are, and the major package that we hold as we move forward is the accumulation of cases. The number is much more than that today, and it will take us a lot of time to deal with this. And the problem of the surgical backlog has been a very hot topic, especially for healthcare consultancy. And this is a report by McKinsey that was published in October, trying to tackle and provide some recommendations to hospital administrations in terms of how to deal with this backlog. So they mentioned that it may take up to 2 years for providers to work through the surgical backlog if they could operate at 10 to 20% above historical levels. Moreover, they started giving, they mentioned many ways by which hospitals can deal with this backlog, and the solutions can be narrowed down into 4 main recommendations. Proactively engage patients and providers to ensure confidence and reduce unnecessary deferral of care. So try as much as possible not to cancel cases that are safe to be done during COVID. Try to engage patients because patients are afraid, patients are insecure about coming into the hospital. Increase effective capacity now to optimize use of existing resources. So hospitals either have to add units and add manpower, or they have to increase the efficiency of the existing resources they have. Utilize advanced analytics to forecast potential patient demand and manage real-time system capacity. So the more you know, the more you will be able to tackle the problem. So gather analytics and know the potential and the surgical backlog that we are building as we go. And reimagine the operating room and inpatient throughput to transform operational efficiency. Again, try as much to modify this surgical workflow to increase the capacity, increase the efficiency to be able to tackle this backlog. Another major topic is the surgical training that has been compromised, and I'm speaking as a resident, giving you real feedback regarding this topic. The surgical load has decreased. Residents are being relocated into different units. The teaching environment is not ideal, and the surgeons aren't at their best psychological teaching mentality. Cancellation of educational activities and conferences internationally, and research studies that have been postponed or delayed due mainly to difficult recruitment during the COVID pandemic. So some systems and some programs tried to deal with this as simulation, transforming education into simulation-based learning, where simulation centers across the whole country were recruited. It allowed direct individualized feedback in the center that is personalized and in real time. However, these simulation centers were also affected by lockdown and social distancing protocols. So another attempt was moving to web-based solutions and content that is present online. However, the difficulty is to provide personalized feedback. So some applications tried to mix to find a common grounds between simulation and web-based education, such as this application where residents in their hospital or in their simulation lab try to perform procedures and then send them to a cloud where they get reviewed by an expert, and they get personalized feedback based on their recordings. And finally, for the insecurity we're living as residents in terms of the accreditation we have, which is the light at the end of the tunnel, if I shall say. The ACGME, the vice president of the ACGME, back in March during a conference stated the following, that safety of residents is the priority. The review committees are aware of case logs being affected, of duty hours and scheduled shifts being missed, and rotations that are also being missed. Programs will not be held responsible for all these mishaps, and efforts to incorporate competency versus time-based learning will be put, so no one would be held responsible for the lack of numbers across the accreditation scene. And finally, thank you. I hope you enjoyed this lecture, and the floor is open for any questions regarding anything that you have to say.
Thank you, Dr. Osman, for this thorough and unique lecture. And thank you, everyone, for joining us today. I hope you enjoyed the lecture. Seems that we don't have any questions in the chat box, but we're going to wait for a couple of minutes in case there are any questions. Okay, so it seems like it was all clear for everyone. Thank you all for attending again, and see you on Friday for the final lecture of our surgical series. Oh, we have a question that's unrelated. Where can we find the link for this recorded session? It will be uploaded on YouTube on our account, Women Surgeons. Okay, in like a few days. Thank you.
Okay, thank you, everyone.
Thank you. Bye.